Postpartum Care Part 2. The first 24 hours after delivery has different types of care than following the first 24 hours. We're going to do our assessments. The vital signs will be the perioperative routine. We'll do the fundal massage and monitor the lochia. We want to encourage breastfeeding as soon as possible following delivery. Mother's activity will be as tolerated, but we do recommend that the feeling returns to her legs if she did have an epidural. And if you encourage mom to kind of lock her knees the first time or two out of bed, she may feel like strength has returned, feeling has returned, and her legs will buckle as soon as she puts any weight on them. No one is supposed to get out of bed without the nursing staff the first few times until they have been cleared by the nursing staff. In other words, we make sure that they are able to tolerate being out of bed without any problems. We'll provide comfort. Ice packs can cause vasoconstriction, and they're most effective if applied soon after childbirth to prevent edema and numb the perineum. Perineal care is done by squirting warm water over the perineum after each void or bowel movement, and then encourage them to gently pat it dry. Don't wipe. Topical medications such as the anesthetic spray can decrease the surface discomfort, and it can allow for more comfortable ambulation. Astringent compresses should be placed directly over hemorrhoids and or episiotomy sites. When mom sits, encourage her to squeeze her buttocks together and sit slowly. We don't use the donuts anymore because that actually puts more pressure on the perineum. Sitz baths can be offered 2 to 3 times a day to those who have episiotomies. And analgesics. We encourage mom to take prescribed medications for after pains and perineal discomfort as necessary. And just one of those cute little slides to help you focus your assessment following delivery. So the focused assessment after a vaginal birth. Again, typically these assessments will be performed every 15 minutes for the first hour, then every 30 minutes for the second hour, and every 40 hours for the first 24 hours. Then if everything is going well, then we go to every 8 hours after that. The vital signs, make sure that you get the blood pressure in the same arm every time and mom is in the same position. Again, orthostatic hypotension is a major risk due to the decreased intra-abdominal pressure, the decreased fluid volume, and tachycardia. The fundus, it is concerning if it's soft or boggy because that means that it's uncontracted, or if it's difficult to locate the uterus, if it's above the umbilicus, or if it's displaced from midline. So if you find one that is elevated or displaced to one side or the other, then encourage mom to void and then recheck the fundus. Again, massage if there's much bleeding. With bladder elimination, encourage mom to go if the urge is present and palpate for the bladder. We always promote bladder elimination. New mothers will have difficulty because of the tenderness, the trauma, decreased sensitivity to fluid pressure in the bladder, edema, etc. Different measures that can be used to promote relaxation would be to medicate for pain, running water in the sink or the shower, putting mom's hands in warm water, and putting water over the vulva. In other words, that squirt bottle, let her just go ahead and pour water over her perineum. Encourage urination in the shower or the sitz bath, providing hot tea or fluids of choice, asking the mother to blow bubbles through a straw. All of these can help with elimination. And if she is unable to void or voids less than 150 mLs, and the bladder is palpable, the fundus is elevated or displaced from the midline, we may have to catheterize. We also want to monitor the lochia and the perineum. We also want to promote regular bowel function. So we'll encourage exercise with adequate fluid and dietary fiber intake. Walking is always going to be one of the best exercises that can be done. Mom's breasts should be soft and non-tender. We monitor lower extremities for signs and symptoms of thrombophlebitis. We may check the deep tendon reflexes, or the DTRs. With cesarean sections, these women will have a Foley catheter, and it is usually removed within 12 hours following delivery. We want to observe the first couple of voids following removal to make sure that mom is not having problems with urinary retention. We encourage turn, cough, and deep breathe every couple of hours, which you do with any surgery, to prevent fluids from accumulating in the lungs and keep the lungs expanded. And we begin ambulation as soon as the client can tolerate it. When I worked in OB, we would set mom on the side of the bed several hours after delivery, and by that evening we frequently even had her out of bed walking to the bathroom, just so we could set her on the toilet and do peri-care, show her what to do. If she tolerated being up, then we allowed her to be up as much as she wanted to be. Her diet, we always begin with ice chips and then advance it as tolerated. IV fluids will continue per physician's orders or until the client is able to tolerate fluids well. We monitor her abdominal dressing, and often that dressing is removed with the first shower. We do not need to replace the dressing after that, but some women like to have something over it. So we usually encourage placing a vaginal pad over the incision. They're the perfect size to absorb any potential drainage. Now, some women will have an abdominal apron that can encourage moisture retention and bacterial growth. So we encourage them to keep that nice and dry. There's also fabric that has been infused with medication to help keep that dry, and at times we will use that to tuck into that abdominal apron fold. We monitor her lung sounds and again development of thrombophlebitis and provide pain management. Now, for all postpartum women, we're going to restore their fluid balance that has been altered by fluid loss of labor and the birth process. We encourage her to drink quite a bit, at least 2,500 mLs a day. If she's unable to tolerate oral fluids, then we will provide these fluids through the IV. We want to encourage a healthy food choice, but at the same time respect ethnic backgrounds. Meals and snacks should be available at all times. Moms tend to be pretty hungry following delivery. And there should be no calorie restriction if mom is breastfeeding. We want to promote rest and sleep because childbirth is highly tiring. At the birth facility, we make every attempt to avoid interruptions to allow for unbroken time of rest. When they get home, we encourage them to realize that fatigue is very common. It's going to last a while, and we encourage them to nap or rest when the infant sleeps. And to help maintain that relaxed, flexible routine, plan simple meals, limit visitors, and encourage them to accept assistance with chores, household, and shopping. Encourage mild exercise that is balanced with rest. Again, ambulation is going to be the primary exercise, but exercise can resume gently with physician okay. Client teaching. You need to figure out what mom needs to know. So make sure that you include topics that are most important to the mother and help develop those topics with her. You need to teach the process of involution, how to assess her lochia, how to locate and palpate that fundus. Emphasize the importance of washing hands before touching her breasts and after diaper changes, after bowel and bladder elimination, before and after handling her pads, and always before handling her baby. Breast care for lactating mothers. They need to be encouraged to avoid soap on her nipples because it can remove those natural lubricants. Encourage her to wear a good supportive bra. If she is not going to breastfeed, then how does she suppress lactation? She needs to make sure that she wears a well-fitting bra or sports bra for at least 24 hours. And apply ice as necessary for comfort. How does she take care of her C-section incision? The staples can often be removed prior to discharge or within 3 to 4 days following discharge. If skin adhesive is used, then there will be no dressing and the mother can shower at any point. Although we do allow showering with that incision, we just don't allow tub baths. With perineal care, make sure she knows how to cleanse her perineum and how to dispose of her pad, hand washing before and after, and Kegel exercises. Those movements can strengthen those muscles around the vagina and the urinary meatus. So she'll contract those muscles, hold for 10 seconds, then relax for 10 seconds. She needs to work up to 30 sets a day. Again, promoting good body mechanics with exercise should be strengthening exercises for abdominal muscles and firm the waist 5 times twice a day, and gradually increase those repetitions as she is physically able to tolerate them and as her physician allows. Use the legs and muscles to squat, no bending, to help prevent back strain. She needs counseling on sexual activity. Again, intercourse can begin when the mother has no bleeding or perineal discomfort, which is usually 4 to 6 weeks after birth. And again, make sure she knows about contraception. Instruct about follow-up appointments that are usually 4 to 6 weeks after childbirth, although they frequently will come in for well mother, well baby exams 2 to 3 days following delivery. She needs to report immediately a fever, any areas of redness, swelling, or pain in the breast or the leg, persistent abdominal tenderness, feeling of pelvic fullness or pressure, persistent perineal pain, frequency urging or burning on urination, an abnormal change in the character of the lochia, an increased amount, resumption of a bright red color, passage of clots, foul odor, etc. The mother should verbalize or demonstrate understanding of self-care instructions. She needs to verbalize understanding of practices that will promote maternal health by the time she's discharged. And she needs to describe plans for follow-up care and signs and symptoms that should be reported to the healthcare provider. Make sure that she knows if she needs to have any postpartum immunizations. And she also needs to learn about newborn care. Length of stays. Most women are allowed to stay in the birth facility at least 48 hours after an uncomplicated vaginal birth and 96 hours for a cesarean birth. Insurance companies are required to pay that much. And chart review. As the obstetrical nurse, you need to check and see if mom needs the RhoGAM injection for a mother being Rh negative and baby being Rh positive. And prenatal screening should have been done to see if mom is immune to rubella or needs that vaccine. These are the usual postpartum medications. Now, just because they're usual doesn't mean that every woman is going to receive them, but they're the ones that we see most frequently in postpartum. With oxytocin or Pitocin, postpartum, mom will receive a IM injection or she'll receive an IV drip for 1 to 2 hours to help control that lochia flow and help encourage that uterus to continue to contract. Methergin can help control postpartum bleeding. Lortab is used for mild to moderate pain relief, as is Motrin. Tylenol is used for mild pain relief. Zofran for nausea and vomiting. Benadryl is an antihistamine. Moms that have an epidural or spinal medication usually will experience a lot of postpartum itching. Rogam is administered for the prevention of the Rh hemolytic disease. Ducalox is a stimulant laxative. And for the babies, the Mylicon drops only should be administered with physician approval, but they can help relieve infant gas. Postpartum complications. Excuse me, we start off talking about postpartum hemorrhage, which is the leading cause of death in women that deliver after 20 weeks gestation. These women have a blood loss of more than 500 mLs after delivery. Now, there's two different types of postpartum hemorrhage. We can have early and we can have late. So with early postpartum hemorrhage, it occurs in the first 24 hours. The most common cause of early postpartum hemorrhage is uterine atony, which is, again, the lack of muscle tone to the uterus. Clinical signs of atony: the fundus is difficult to locate. There may be a soft or boggy fundus on palpation. The uterus becomes firm as it's massaged, but it loses tone when the massage is stopped. The fundus is located above the expected level upon palpation. Excessive lochia, especially bright red in color, and excessive clots have been expelled. So what do we do for this? Well, you want to massage that fundus until it's firm. Have the client empty their bladder to see if that's the cause. Oxytocic medications can be administered, such as the Methergin, which will stimulate continuous contraction of the uterus. A laparotomy may be necessary to identify the source of bleeding. With a late postpartum hemorrhage, this of course will occur after 24 hours and up to 6 to 12 weeks after birth. The most common cause is the subinvolution, or that delayed return of the uterus to its non-pregnant size and consistency, and retention of placental fragments. Predisposing factors to this late postpartum hemorrhage is the manual removal of the placenta accreta, a previous C-section, an attempt to deliver the placenta prior to separation from the uterine wall. We manage this or treat it by managing or controlling excessive bleeding. Again, administering oxytocic medications is ordered. Prepare mom for a D&C if necessary. Administer broad-spectrum antibiotics if we suspect she may have an infection. Trauma can include vaginal, cervical, or perineal lacerations or hematomas. Lacerations are really common, and many of them don't require any type of repair. Hematomas or bruising, again, is bleeding into the loose connective tissue. Nursing interventions. Prepare mom for surgery as it's often necessary due to the trauma. Now, small hematomas can resolve on their own and usually do, but large ones can require incision and evacuation of the clots and litigation of the bleeding vessel. So the client needs to be prepared, and you need to support her emotionally because she can be anxious or fearful. and make sure that you give analgesics as necessary. Hypovolemia is a common postpartum complication because of excessive blood loss. Signs and symptoms will be mild tachycardia, hypotension, narrowing pulse pressure, pale skin that's cool to touch, and it can progress to being cold and clammy. We intervene by managing the bleeding, preventing hypovolemic shock from becoming irreversible. In other words, treat it quickly rather than letting it continue. Make sure mom has a large bore IV for heavy fluid infusions, and infuse those IV fluids as ordered. Monitor her output. We should see at least 30 mLs per hour. We may need to administer vasopressors. We may need to prepare her for surgery, for possible uterine packing or ligation of the uterine blood vessels, ovarian or hypogastric artery, or a hysterectomy. Monitor her vital signs every 3 to 5 minutes. Monitor the fundus location and consistency, the amount of lochia, her skin temperature and color. Assess capillary refill. Administer oxygen at 10 liters per face mask, and administer blood as necessary. With postpartum depression, this is persistent depression that will start after childbirth and will last a minimum of 2 weeks. Now, there is a difference between postpartum blues and postpartum depression. The postpartum blues is usually self-limiting. It's described as more of an emotional letdown following delivery. But with postpartum depression, we can see a depressed mood, a loss of interest in most activities, changes in appetite or weight, changes in sleep, changes in psychomotor activity, decreased energy, feelings of worthlessness or guilt, difficulty thinking, concentrating, making decisions, recurrent thoughts of death or suicide, or plans or attempts. The client can be treated with psychotherapy, where the client goes and talks with a therapist, social support, and medications can be used to treat. And sometimes a combination is used to get the best benefit for the client. Postpartum infection, or puerperal infections, is a bacterial infection after childbirth. Moms have a fever of 100.4 degrees or greater after the first 24 hours following childbirth. Nursing interventions for these infections: place her in the Fowler's position to help promote drainage of lochia. Administer analgesics for pain. Assess her for signs and symptoms of improvement or worsening condition. Every 2 hours if a fever is present, and every 4 hours if it's not. Encourage foods that are especially high in vitamin C. Educate on signs and symptoms of worsening conditions, and apply comfort measures such as warm blankets or cool compresses, cold or warm drinks, or even using heating pads. And venous thrombosis. This can happen in 1 in 1,500 pregnancies. Pregnant women are at an increased risk due to venous stasis and increased levels of fibrinogen and other clotting factors. We treat it with heat application, elevate the affected leg, anticoagulation, and teaching them on how to prevent. So postpartum complications, those are just some of the main ones, definitely not all of them. Postpartum concerns. We need to make sure that mom has a good support system after discharge. If she doesn't have that good support system, then she's going to tend to overdo when she's doing just her routine activities. She's going to be fatigued, and her rest is very important. She will have some weight restrictions following delivery. Usually, mothers are told not to lift anything heavier than their newborn for the first couple of weeks. And taking care of a new baby is very stressful and it's very exhausting. Younger mothers may require additional teaching prior to leaving. Single mothers may not have adequate support system in place. A lot of them have to return to work too soon because of finances. Indigent families can sometimes just adding another mouth to feed to the family can be very stressful because of those finances. We do social service referrals for indigent families. Young mothers who delivered at an age where statutory rape is a possibility. Adoptions. Mothers who have known substance abuse. Or any mother who has concerns concerning discharge. In obstetrical nursing, language barriers are very common, so make sure that you have an appropriate translator. Assure understanding of all procedures and teaching. Assure that those clients and concerns have been addressed. And try and locate and distribute written material in the client's language so they have material to refer to following discharge. And perinatal loss. We don't like to think about it, we don't like to talk about it, but these do happen. Perinatal loss is any time during the pregnancy. It can be called fetal demise, stillbirth, or neonatal death. Grief responses. We usually will place a chart on the door or a symbol on the door so any hospital staff that comes into contact with the family is aware of the situation. Mother and or any family may cry a lot. In fact, they probably will. And feelings of anger are very normal. The parents often will experience guilt because they start looking for a reason why their baby died. And it may be something very simple, such as a missed prenatal vitamin. And they'll place all kinds of guilt on themselves because I missed that prenatal vitamin and it killed my baby, when that's probably not the case. In fact, I can assure you that a missed prenatal vitamin will not be the case of a perinatal death. Make sure that you watch for subtle signs such as sighing, excessive sleeping, poor hygiene, and loss of appetite that really indicate not coping well with the situation. Allow the parents to express their feelings. Acknowledge the infant by allowing the infant to be named and recognized as a person. Allow the parents to be seen, touched, and or held by the family. Allow that infant to be put to rest with dignity. Some of those newborns come out not looking very, very pretty, so you may need to apply some lotion or powder and always wrap them in a soft warm blanket. Usually we will also dress them in a special little shirt that has been provided. Allow the parents to assist with bathing or dressing if they desire. Try and, if they're going to do any visiting with a baby, to let them do this while the infant is still warm, if at all possible. And if there's any defects, obvious defects in the fetus, then try and hide those defects if possible. Most facilities will prepare a memory packet, excuse me, such as footprints and a lock of hair, etc. Pictures. Respect cultural practices and assist with any other needs. This is a tough time and it's never easy.